So if anybody has coffee today and is stirring their coffee with these little straws, these little coffee stirrers are about 3 millimeters in diameter, and that's about the size of the human coronary artery in an average sized male. So these are really small arteries, and it makes it so much, so fascinating what we can put in those arteries. We're putting ultrasound cameras, lasers, balloons, stents in those arteries. So let's talk about what's happening in the wall of the artery. Take a look at this cartoon here, and what it's describing when you look at the cutaways of the longitudinal sections of the arteries is the different coronary syndromes, if you will. If you look starting at the top, the plaque with the fibrous cap, that is an example of what you might find in a patient with stable angina. And in a patient with a coronary stenosis that is restricting blood flow to the artery, at rest anyway, the EKG will be normal. At a certain point in time, that plaque ruptures just like a volcano. And when it ruptures, as we'll talk about, you get some instantaneous thrombosis. That thrombosis and the combination of thrombus and plaque can partially or completely occlude the artery. If it's partial, then typically you might get ST segment depression or T-wave inversion on the EKG. And those patients suffer either unstable angina, a change in their pattern, or a non-ST segment elevation myocardial infarction. And then finally at the bottom, the mother of all acute coronary syndromes, the blood clot and the plaque combined completely occlude the artery, and now no blood flow is getting to the heart muscle. In this case, the ST segments go up, and this patient is having the largest kind of heart attack you can have, or the ST elevation myocardial infarction. So just think about what's happening in the coronary artery, how it correlates with the finding on the EKG, and how it correlates with what is actually happening clinically with the patient. Take a look at this cartoon, and it's showing you this cross-section of the artery. And to walk you through it, what happens in the patient with coronary artery disease is that elevated, at least for that person, elevated levels of LDL cholesterol become oxidized, and that oxidized LDL finds its way underneath the endothelium. That's where it likes to gather. But that actually incites an inflammatory process, and so our circulating white blood cells are then called via molecular signals to clean up the damage. This is what our white blood cells do. This is what inflammation is. As I often say to my medical students, if I drop a boulder or a bowling ball on my toe, what happens? After a while, it inflames, it enlarges, it gets red, it gets hot. That's because the white blood cells are called to that toe to clean up the damage, so to speak. Well, the same thing happens in the arterial wall. The oxidized LDL is an irritant, and so the white blood cells find their way underneath the endothelium to clean up the damage, so to speak. Once they're there, they do what white blood cells do. They release their inflammatory enzymes, but there are also growth factors there that cause growth of vascular smooth muscle cells and fibroblasts in the area. Over the years, this can be a cycle that grows, and as this cycle continues, that plaque size grows and begins to impinge on the coronary lumen where the blood flows. That fibrous cap can also weaken. Years of physical forces such as high blood pressure, or those enzymes slowly eating away from the inside at the underneath of that fibrous cap can weaken the cap. And then one day, one fateful day, after years of this cycle, you get a breakthrough through that fibrous cap. And now the flowing blood comes into contact with what is underneath the endothelium. We call that a plaque rupture. And because all of that cholesterol and dead white blood cells is very highly thrombogenic, when that content comes into contact with the flowing blood, it causes almost instantaneous thrombosis. If that thrombus only partially occludes the artery, that is, some blood flow is able to squeak by, again, the ST segments go down, and the patient is usually having either unstable angina or a non-ST segment elevation myocardial infarction. However, if it's completely occlusive, no blood is getting to the myocardium, the ST segments go up, this patient is having an ST elevation myocardial infarction. This next couple of slides is just to show you that this is a very controlled process. These white blood cells are called via molecular signals to the area of inflammation, and through a very tightly controlled system, they actually find their way underneath the endothelium. And that's what you see here in this picture. So the top of the picture represents the lumen where the blood's flowing. You see the white blood cells or monocytes there, and they are going to get underneath that endothelium where their job is to ingest that lipid. Now that's a receptor-mediated process, again, very tightly controlled by molecular processes. And so what happens is these white blood cells get underneath the endothelium, they ingest the lipid, and then they can't get back out. So they're stuck. And they live the remainder of their life down there. And when they die, they burst open, releasing their enzymes. Those enzymes then begin eating away at the fibrous cap. So again, just to show you that there are receptors on the white blood cells, receptors on the endothelium that link up. And so there is a molecular biological control of this process. Once you get a number of these, thousands of these cells clumped together in one place, you can actually, by light microscopy, see what are called fatty streaks on the wall of the artery. And this is the very early beginning of the atherosclerotic lesion. Over 20 to 40 years, this plaque continues to grow if the risk factors are not treated. And the cross-section here of the human coronary artery, you see, if you look at the inside where the lumen is, that intima, as we call it, you will see that in between the intima and the adventitia, go out to the adventitia where you see fat surrounding the artery, and you'll see kind of a thick external elastic lamina. Everything in between there, that white glistening stuff, should not be there. That is all cholesterol and the ravages of white blood cells and even hemorrhage where it looks orange. So this is what happens. It takes years until, again, that plaque ruptures and then the patient has a heart attack. So from the upper left of the screen to the bottom lower of the screen, these are human coronary arteries before and after a fatal acute myocardial infarction. Down at the bottom, what you see is the TH is thrombus. That's in the lumen of the artery. And the arrow is actually pointing to the fibrous cap. Underneath that, you see the fat, the lipid, and there are white blood cells in there that broke through that fibrous cap. And for this patient, that resulted in sudden cardiac death.